Welcome to the National Center on Substance Abuse and Child Welfare's Dialogue with Expert series. Today on Sobriety, Treatment and Recovery Teams, START, an evidence-based program for families affected by substance use disorders and child maltreatment. And I'm so sorry for the background noise. We want to thank you for joining us this afternoon, and we're really excited to host this latest round in our webinar and dialogue series. This presentation was developed by the National Center on Substance Abuse and Child Welfare, which is an initiative of the Department of Health and Human Services, jointly funded by the Substance Abuse and Mental Health Services Administration Center for Substance Abuse Treatment and the Administration on Children, Youth and Families, Children's Bureau Office of Child Abuse and Neglect. And we thank them today for this opportunity.
Good afternoon, everybody, and welcome to our webinar. My name is Tina Willauer, and I'm the director of the National START Training and Technical Assistance Team at Children and Family Futures. Thanks so much for taking time out of your schedule to join me today and to learn more about START. I'm glad to be with you today. So a quick overview of what we're going to be covering in today's webinar. We're going to talk about the purpose of START, why it was developed, how it's evolved into an evidence-based child welfare service delivery and practice model, and the outcomes, lessons, and considerations for implementation. I'm going to be providing you with a lot of information about START today. So remember to put your questions in the Q&A box and also join us for Thursday's session. So before we get started, I have to acknowledge and introduce my amazing team who's working hard to help our START affiliates reach fidelity and to build our team's capacity and readiness to expand in new jurisdictions. This slide shows the National START Training and Technical Assistance Team, and they're really a dynamic group of individuals who bring great skills and experience to the team. And they're really committed to helping jurisdictions implement the START model. Many of them have actually worked in the START model in their communities. So that's really helpful. Our change liaisons provide training and technical assistance to our START affiliates. And our team includes both programmatic and evaluation technical assistance since they're so closely aligned in START. So let's lay the foundation for what we're going to be discussing today. And thinking about the work that we do with families, it's just really important to consider the connection between substance use and child maltreatment. Now, if you're tuning in today, chances are that you already know the research that tells us that children whose parents have a substance use disorder, they're more likely to experience abuse and neglect compared to children who live in a household where substance use is not present. In fact, research tells us that 1 in 8 children, or about 8.7 million children in the United States, lives with at least one parent who has a substance use disorder. It's about 12.5% of our children in this country. So that's a lot. We also know that foster care numbers in our nation declined for nearly a decade. In the early 2000s, we actually made it down to a low of 397,000 children in foster care before that trend began to reverse in 2012 and 2013. Now we know that a common factor driving that increase has really been a surge of substance use by parents. And we know that children whose parents have a substance use disorder are likely to remain in the child welfare system longer, and their outcomes just aren't as good. The good news is that through collaboration, cross-systems linkages, and teamwork by all family-serving systems, we can achieve better outcomes for all families affected by substance use disorders. So let's move on to the next slide. We know the problem is large in scope, and we just talked about the numbers of families who are affected by substance use in our country. And many times our systems, and I'm speaking of child welfare, treatment, judicial, and other family serving systems, we struggle to help sometimes. Sometimes we aren't sure what to do, and sometimes we don't have the collaboration in place to adequately serve families. And that's where START comes in. While START's a service delivery practice model for families in the child welfare system with substance use, we also refer to START as a catalyst for systems change. Together in START, we work to change the system so it can better serve families with substance use. And by the system, we're referring to how child welfare, treatment, and other agencies work together to serve families, since we know no one entity can do this work with families alone. We know that relationships, resources, and results lead to larger systems change, and this is where we're ultimately headed. So let's take a deeper look at the START model, where it came from, why it was developed, and the positive outcomes for children and families. Now, I love this slide that's up right now, and if I were in person, I would ask you, yeah, good, Carissa, thanks. If I was in person, I would ask you for a show of hands to say who has initiative fatigue. During the opioid epidemic and the pandemic, there has just been a lot of funding come through, a lot of opportunities for new initiatives and programming in our communities. Now, we know initiatives come and go, and sometimes we don't trust that they'll stick around, but we ask that you think about START as not a new initiative, but a new or different way of doing business with families that have substance use, and a model that actually has proven results. We also know that working with families with substance use is hard, it's confusing, and it can be exhausting. So having a model like START can help teams feel that they are being more effective with families. And the practices of START often spread to the rest of the office, resulting in change practices that help all families. And slowly, together, we begin to change the system. So I want to spend a little time talking now about the history and the evolution of START. The history is super important because it shows how the essential components of the START model today really grew from the needs of families and practices that evolved as we learned more about what was effective when serving this population of families through the years. The model began as the Alcohol and Drug Addiction Protection Team, ADAPT, in Lucas County, which was Toledo, Ohio, in 1989, amidst the crack cocaine epidemic. I was lucky enough to begin my early career working in child welfare as an ADAPT caseworker, and I've worked in START ever since, almost 30 years. We knew in Toledo that ADAPT was a great model, but we didn't have data collection and we didn't have a large scale evaluation. So we only knew anecdotally that we were making a difference in families' lives. So that program did not last long term. However, some of the child welfare leadership in Toledo at the time and implementers of ADAPT moved to Cuyahoga County, which is in Cleveland, a couple hours down the road in northern Ohio, in the mid-1990s. And that's where they worked closely with the Annie E. Casey Foundation on the Family to Family Initiative, which focused on the improvement of child welfare systems and outcomes for children and families through the use of a variety of strategies and programming. START was one of the programs that came out of the Family to Family Initiative. And the model, we really build on what was accomplished with the ADAPT program in Toledo, but with some specific goals and changes in mind. And for context, it was still the crack cocaine epidemic. High numbers of children were coming into relative and foster care due to parental substance use, and particularly infants with prenatal substance exposure. And the outcomes were poor for many families. Now, the Adoption Safe Families Act, or ASFA, was enacted in 1997, around the same time that START was developed. And this is really important. As a reminder, ASFA requires states to file for a termination of parental rights, or TPR, once children have been in foster care for 15 out of the most recent 22 months, except in certain allowable circumstances. And in Ohio at the time, that time frame was shorter. It was 12 out of 22 months. So due to that shorter time clock, and knowing that the substance use disorder treatment and recovery process can actually take a very long time, longer than that defined time frame that ASFA laid out, there was a real recognition in our community and a real sense of urgency to work with intention and in a different and more collaborative way to improve outcomes for children and families in our community. And this recognition and commitment to more collaboration included child welfare, our treatment providers, the courts, and other family serving agencies in our community. Now, there were challenges in the early days of ADAPT and START. As you know, in your communities, building cross-system collaboration is not easy work. There was a need to learn about each other's systems and the mandates and the language that we use and all those acronyms, and to align our vision and values as a collaborative group. In other words, we had to develop our partnership and our approach to serving families in a more collaborative way. And we did that for a very long time. And while all that good work was happening in Cleveland, there was another epidemic that was emerging. So fast forward to 2007, and we're amidst the opioid epidemic in our country. And Kentucky was really at the epicenter of that entire problem with both pills and heroin. So what's the issue Kentucky was trying to solve by implementing START? Interestingly, some of the very same issues that we faced in Ohio during the crack cocaine epidemic in the 1990s, rising numbers of children in foster care, now really high overdose rates and deaths, and more trauma to families. So there was a real sense in Kentucky, a real desire and sense of readiness, if you will, for more cross-system collaboration. And we really, really wanted to use a less punitive approach in child welfare, with more of a focus on family engagement and building on family strengths. There was also a recognition by child welfare leadership in Kentucky that we needed to use data and program evaluation to see what worked and what didn't work, so that we could begin to focus our resources on practices that actually had evidence of effectiveness. And with that in mind, the Kentucky Child Welfare Commissioner at the time put Dr. Ruth Hebner, who was a child welfare researcher on staff at child welfare in the state office in Kentucky. She was charged with actually evaluating START. So that was a really smart move. And we'll talk about why later. So we began in Kentucky implementing START in 3 unique jurisdictions in 2007 in both urban and rural settings. Kentucky was the recipient of 2 regional partnership grants in 2007 and 2012 that were absolutely instrumental in START's growth into an evidence-based practice. Rigorous program evaluation and testing of the model occurred during this time, and we learned so much about our model and about what worked with families. In 2008, we began focusing on replicating the model both within our state and outside of our state, because there was a lot of interest in what we were doing. START pilots occurred in Indiana, in the Bronx in New York City, and Northwest Georgia. And by 2016, we had built the evidence base of START to the point that we were added to the California Evidence-Based Clearinghouse for Child Welfare. And in 2017, we established the National START Training and Technical Assistance Program to prepare for scaling up and replicating the model in other jurisdictions. And then, the best news, START was added to the Title IV Prevention Services Clearinghouse in December of 2020 as a promising practice. This allows states to draw down Title IV prevention services funding to support and sustain START, as long as START is included in the state's approved 5-year prevention plan. So it started as a response to the events that were happening to a lot of children and families in a variety of different communities. We ended up with an evidence-based program that's focused on child safety, recovery, family unification, service delivery, and systems transformation. I just wanted to point out that we're going to put a few links in the chat box for you, links to both of the clearinghouses that I mentioned, the Title IV Prevention Services Clearinghouse, and also the California Evidence-Based Clearinghouse. We're also putting a document, actually it's a publication called Navigating the Pathways, Lessons and Promising Practices in Linking Alcohol and Drug Services with Child Welfare. This highlights 7 case studies in jurisdictions across the country that really implemented programs that with this population, and START in Cleveland was one of those programs that was highlighted. So moving on, let's look a little bit more at the evolution of START over time. So I talked about 2007 is when this began in Kentucky. And at the time, Kentucky allocated $2 million in TANF funding to pilot START. And they continued this seed funding for several years as new counties came on board and expansion within those counties occurred. Now, the federal support that we received was critical in the growth of the START model. Being a part of that regional partnership grant program, RPG, that I talked about for rounds 1 and 2 really propelled START forward in so many ways. Not only just by grant funding, which was important, but we also learned about best practices and other innovative programs from around the country. RPG required rigorous testing and use of data, which aligned with Kentucky's vision for evaluating START. And we had a national network of peers to learn from, which was amazing. And then we also received technical assistance through the National Center on Substance Abuse and Child Welfare. And we learned about best practice strategies, how to implement the model, the parameters of the grant. It was all just really important. Now, during that time, Kentucky was also the recipient of in-depth technical assistance, IDTA, also through the National Center. This helped really bolster the collaborative work at the state and system level in Kentucky. And it contributed to leadership buy-in and practice change statewide that lasted over the decade. So the federal support and the technical assistance we received during this time really helped us to refine the model. And so a little bit about that. Some of the things we did in Kentucky. First off, we already knew that START worked well in an urban setting from our work in Cleveland, Ohio. But we wanted to test and refine the model to also work in a rural setting. So our first regional partnership grant test site was Martin County, Kentucky, in rural Appalachia. During this time, we tested the model in both urban and rural locations in Kentucky because we wanted to know what the implementation needs were in both settings. And we now know that the model does work in both settings. The initial target population for START in Cleveland was families who had an infant with prenatal substance exposure. But after reviewing Kentucky data and prior to selecting the sites where we'd implement START, some of our smaller communities didn't identify enough of those families to support a full START team. So we expanded the target population to include families with at least one child, age 0 to 5, still focusing on infants with prenatal substance exposure. We really had a stronger in-home prevention focus in this period of time in START. Our attempts to avoid family separation were even more deliberate. And this was a real paradigm shift that took some time to implement, but it was absolutely the right way to go. START improved and refined its approach to be more family-centered. So we were providing services for parents, children, and the family collectively, which included its extended caregivers, resource parents, and anybody attached to the family system. And it meant that we had to make sure our services and our approach focused on building and strengthening that bond between parents and their children. There was also a big focus on trauma and mental health needs for both children and the parents. And so we worked to strengthen and develop services that would meet this need. And finally, we refined specific START practices. So we defined the START timeline, which I'll talk about in a minute. That actually outlines the first month of a new START case. We developed the START minimum work guidelines and the family mentor hiring guide, which is a non-traditional 3-step hiring process. So this time period between 2007 and 2017 was a great time of learning and growth for START. And we're grateful for the federal support and the leadership that paved the way for this work. On the next slide, you'll see START states. You can see we are in 6 states right now, soon to be 7. And the implementation approaches and START jurisdictions look different depending on the geographic location, size of the community and child welfare agency, the need, and funding. Some jurisdictions begin small and implement START with a partial team, while other jurisdictions install a full team when implementing the model, meaning that they have 3 or 4 caseloads per team, which is often the best approach because we want to make a larger impact. So you can see that START currently is in Kentucky, Kansas, Maryland, North Carolina, Ohio, and West Virginia. And we need to update our map to include our newest affiliate, Helena, Montana. All right, let's jump into what is START. So START works with families involved with the child welfare system due to co-occurring substance use and child maltreatment, and the families who have at least one child aged 0 to 5, and again, including infants with prenatal substance exposure. START serves some of the highest risk cases due to the age of the children, and we know that they're most vulnerable when there's substance use present. START uses a group of strategies and an accelerated timeline. It's really the basis of the START model. START identifies and engages eligible families earlier than in traditional child welfare cases and provides quick access to intensive and quality substance use disorder treatment services. We strike while the iron's hot during what may be considered a crisis with that new report to Child Protective Services, and we use that crisis to maximize the opportunity for engagement with the family. The idea is that the parent, if the parent thinks they might lose custody of their child, that sometimes can be a motivating factor on their decision to enter treatment services, and we want to be there to help them do that. Our goal is to help parents achieve recovery and maintain children in their home whenever it is safe and possible to do, which is why we engage families so early. START works with substance use disorder and mental health treatment providers to provide intense and coordinated services for the family. And again, START's family-centered, which means we serve everybody, the parents, the kids, the caregivers, the extended family. We focus on that bond between parents and children. And families are seen as partners in change instead of recipients of services. Again, a paradigm shift that really involves an element of power sharing. It's really an important piece of this model. We use a strength-based, not deficit-based approach, meaning that we help families identify and build upon their strengths, instilling a sense of hope and emphasizing that they are resilient and capable of reaching their goals. Shared decision-making is critical. It's central to this family-centered approach, and I'll talk more about that in a minute. And lastly, we know no one system can address all the needs of families. We know we can't do this work alone, so we use START to transform how the system interacts with and on behalf of families, which includes child welfare, treatment providers, the courts, and other family-serving systems, all in an effort to improve child and family outcomes. In your chat box, you're going to receive a link to our family-centered approach modules that were developed by the National Center on Substance Abuse and Child Welfare to help communities move towards family-centered care. So what are the goals of START? Well, first and foremost, START's focus is to ensure child safety and well-being. We look to prevent and decrease out-of-home care placements by keeping children in the home whenever it's safe to do so, thereby reducing the total number of children in out-of-home care placements. In START, we support, encourage, and lift parents up so they have the tools and support necessary to enter into and sustain their own recovery. We work to increase the knowledge and skill sets of the parents to help build parental capacity and to help them to stabilize their family situation. And finally, we're looking to create a new way of doing business by changing the system's ability to address substance use disorders and child maltreatment. We want all families, not just START families, to have rapid access to quality treatment services at the intensity level that they need. On the next slide, let's talk a little bit about START components that actually make up the model. So the first thing to really understand about START is that it's not a treatment program. It's an ongoing collaborative service delivery program for families in the child welfare system. It could actually be thought of as a specialized unit in the child welfare or child protective services system. A START team consists of a group of dyads, and a dyad is one child welfare caseworker paired with one family mentor, who is a person in long-term recovery from their own substance use disorder and who has past lived child welfare experience. And we'll talk more about both of these roles in a minute. Both are child welfare employees, and the dyad actually shares a START caseload together of no more than 12 to 15 families, and sometimes less, depending on the jurisdiction. START uses shared decision-making in all that we do with families and within our own team, because we recognize that every individual on the team brings a unique perspective and should have a voice in the decisions made in the case. We find that everybody's more engaged and bought into the plan if they've had the opportunity to participate in the planning. One of our mantras is nothing about me without me. And for the professional team, this reflects a value that any decision or action regarding the family should involve the family, so that there aren't any secrets or surprises for our families. Once a case is referred to START, an initial family team meeting or a shared decision-making meeting happens, and START begins providing intensive case management and treatment services, weekly visits to support ongoing engagement and re-engagement of the parents into treatment, and we connect them with recovery supports in the community. We use rigorous program evaluation design and collect ongoing data. We review it regularly so that we can make better decisions about the model based on what the data is actually showing us. So let's talk a little bit on the next slide about the systems of care. Every EBP model is based on theories of change that guide how the components are set up and that try to explain why it's effective. In START, how we approach families and the strategies that we use with families are grounded in several theories of change found in social science. I'm going to briefly go through them. First is attachment theory. Relationships matter. Parents and young children need strong attachments for normal development and well-being. And START focuses on strengthening that attachment by trying to keep the family together so they can learn to be parents and bond as a family as they enter into recovery. START uses frequent contacts with families and lots of parent-child time if there does have to be an out-of-home care episode. Self-determination. It's a powerful force for behavior change and empowerment. And in START, we adhere to the principles of self-determination theory. Even in the depth of the substance use cycle, it is important to treat the parent as they are capable of becoming, because they are. We value and encourage parents and families to be a part of the shared decision-making process, as I just talked about, with the nothing about us without us. And then we have the crisis theory. The idea is the best time for change is during a crisis. And I talked earlier about ASFA and those shorter timeframes for families. And that START uses an accelerated timeline to maximize on that initial crisis that families experience with child welfare when a CPS report's called in about their family. We use that crisis as a time to intervene and engage with the family with the idea that they are more likely to agree to services during this crisis period of time if we engage properly. Readiness to change, or the stages of change theory. We know that when families enter the child welfare system, they're not in an active stage of change. They're usually in a stage of pre-contemplation. And we see it as our job to help them move into a more active stage of change by engaging through motivational enhancement practices such as motivational interviewing. Trauma-informed care. Parents and kids are likely victims of trauma and need safe environments. So START uses strategies and treatment programming to address this need. NIATEX, the Network for the Improvement of Addiction Treatment. We've learned along the years that small changes can make big improvements for access and retention in substance use disorder treatment. Now in START, we don't use the rapid cycle change process of NIATEX, but we do use their focus on access and retention in treatment as part of our theory of change. And finally, neurorehabilitation theory. Substance use disorders compromise the brain structure and function. And we know that addiction is a brain disease that requires structure, coaching, and guidance to heal and to improve sober living and parenting skills. And those are many of the things that START helps parents with throughout the life of a case. The family mentors are great at helping break down those large tasks into manageable next steps, and also in providing support along the way. So that's a quick snapshot about the theoretical foundation on which START was built. So where does START fit into the systems of care? Well, START's based in the Child Welfare Office, meaning that it's where the START supervisor, caseworker, and the family mentor are located. And that's where the referrals come from, since it's a child welfare-based intervention. But we partner and collaborate with the substance use disorder treatment providers, courts, and other family serving systems to help families reach their goals. START's absolutely a cross-system collaborative model that uses a variety of strategies to help engage and create collaboration between all the systems working together. We used to think about it like a triad: child welfare, treatment, and the courts. But that's much expanded, and we know much more now. So other systems and agencies are involved: maternal and child health, early childhood, housing, fatherhood services, veteran family services, early care and education, and other community-based supports, including the recovery community. In START, we wrap around families, bring all the system partners together to assure that that family has a voice in what they would like to see happen with their family and in their treatment and case plan. And then we tailor services to meet both individual and family needs. We develop common goals, case objectives between agencies, and we jointly monitor the family's progress toward the agreed upon goals. And I love this next slide. It's the spirit of START. At the heart of START is a philosophy or a spirit that represents how we approach individuals and families dealing with substance use disorders. In START, we approach them with compassion, understanding, and hope for recovery. This philosophy is weaved through all that we do, from how we work as a team, supporting and holding each other accountable, to how we interact with our families. We believe in family, love, and redemption. And this just really sums it up, the work in START. And here are some of the ways our actions in START embody the spirit. You'll see it in our selection of staff. You'll see it in the way we build our START teams. You'll see it through case reviews. It's reinforced in START meetings and how we make decisions as a team. You'll hear it in our language, how we talk about and to families, and in our non-punitive, strength-based approach. We really see it as our job to role model this compassion and love in our communities when we work with families. All right. So timely access to intensive services. The matter of time in our work with children and families is critical. There's a real sense of urgency already to help individuals who have substance use disorder, but there's even potentially a heightened sense of urgency when we consider the effects of parental substance use on kids and families. We must consider child safety as well as the needs of the parents in START. I talked earlier about the Adoption Safe Families Act and how that provides a short time period for parents to complete services and to make a stable environment for their children. We know recovery from substance use disorder doesn't fit into this ASFA time frame very well, especially if there's a relapse or if there isn't timely access to treatment. We also need to consider the child development clock timetable, another critical clock due to those formative years when bonding and attachments occur. So there's really no time to waste when it comes to the needs of kids and families in the child welfare system. And basically, this is what START was built around, this very premise. So instead of what used to be a traditional way of doing business in child welfare, START accelerates the timeline of service delivery, that beginning with that initial report to child welfare. Again, we're attempting to engage early with families in a non-punitive and collaborative way, which brings us to the START timeline on the next slide. So the urgency from these clocks is why we developed the START timeline, which outlines the initiation of a START case and the activities that occur at key points in the first month of the case. It's a way of operationalizing early identification of families in the child welfare system who need treatment and quick access to treatment services. Each step of this timeline requires collaboration, coordination, communication, and information exchange. So START jurisdictions use the timeline to help guide the development of agreements, protocols, services, and data collection. So you can actually think of the START timeline itself as a measure of collaboration, since it's impossible to adhere to these standards without a strong collaborative partnership between child welfare and the treatment provider. Frontline staff in both child welfare and treatment use this to guide their everyday work, and evaluators use the data that's input about the timeline to help with reaching and maintaining fidelity to this important part of the model. We know from research on treatment effectiveness, such as the work done by NIATEX and the Washington Circle, that people who get into treatment quickly and keep going for at least the first several sessions are more likely to successfully complete treatment. And we incorporated this knowledge into the START timeline, trying to move parents quickly through a substance use disorder and mental health assessment and into the right treatment for them, using lots of strategies to keep them retained. The timeline reads left to right, and the colored boxes let you know the time frame to complete each of the activities in the corresponding box. Starting with early identification of eligible START families, we actually ask that the child welfare assessment or investigative worker refer families to START within 14 days from the initial report to the hotline. Once referred to the START team, an initial shared decision-making meeting is quickly held to discuss the plan to keep the children safe and arrange services to support the family. At this point, START service delivery actually begins while the investigative or assessment worker continues finishing up that part of the case. So as you can see, according to the timeline, within the first month of that initial report to child welfare and before the initial assessment or investigation is typically concluded, the goal is that the family has been referred to START, the parents have participated in their first shared decision-making meeting of the case, they've gotten their substance use disorder assessment, been referred for treatment, and attended a minimum of the first 4 treatment sessions. And then at the end of the month, that first month, we have another shared decision-making meeting to be sure of the alignment of the treatment and case plan. Now, under each of these steps along the timeline, jurisdictions need to think about how to operationalize each step, and that may require a protocol to figure out how to manage that activity. New sites are typically really concerned about achieving the standard of accelerated service delivery and decision-making. And it is overwhelming, but we have to remember, START is a complex system improvement model, and efforts are long-term endeavors. Change can be challenging, and sometimes it might seem impossible, but even small changes make a difference. And a lot of small changes can result in big system changes that actually benefit families in the long run. And you'll see what I mean on the next slide, which we lovingly referred to as the money shot. It's a lot going on here, so let me break it down for you. Implementation science tells us it can take site 2 to 4 years to fully implement an evidence-based program. Installing and implementing START is hard work, but it's worth it. We know that it takes time, and you saw on the last slide that it can absolutely take time to build that kind of a collaboration to make that happen. We know that the ability to meet timeframes is a reflection of the collaboration happening between child welfare and internal the START team, as well as substance use disorder treatment providers. And that timeline represents some of those important parts of START fidelity. So this slide shows how adherence to the timeline actually results in improved outcomes. And it shows Kentucky's experience implementing the timeline during the time that we were rigorously testing the model between 2007 and 2012. So the red line represents the time from the initial child welfare report to the first 4 treatments. So that's to the end of that timeline that we just looked at. You can see in year 1 in Kentucky, we took us 122 days to get families through that initial timeline. And remember, that's the first month of the case. The problem was we didn't have quick access to treatment. We weren't that great at identifying cases early. We still had a lot to learn, and we needed to have better cross-system collaboration. So you can see at the bottom, year 2, we're getting a little bit better. It took us 80 days. And then by year 3, we reached full fidelity. But look what happened during that time. As the rate or the time that it took us to actually move families through that first month, that's the red line, you can see what's happening with the other lines. As we got quicker to adherence to the timeline activities, the rates of mother sobriety increased, and that's the green line. Fathers also had better sobriety rates by the end of the case closure too, and that's represented by the blue line. And as we got better adhering to the timeline, remember, early identification, quick access to treatment, that timeline, children were also more likely to remain in their parents' care and custody throughout the case, and that's the purple line. So the number of days it takes to get into services quickly has an effect on positive outcomes for parents and children. But again, it took us time to get there. It took a lot of work to get there, and actually by year 3, we made it. So fidelity on the next slide. Let's talk a little bit about it. If you've ever implemented another evidence-based practice model, you're likely familiar with the term, and we talk a lot about it in START. The definition of fidelity is adherence to the standards and principles of a program model. Another way to say it is implementing a program as intended. With START, implementing this program with fidelity helps achieve similar outcomes, and I'll share about those in a little bit. There are 11 essential components that make up the framework for START, and each of those components has a fidelity standard that goes along with it that's operationalized into policies and practices as you implement the model. We know it takes time to get everything in place, and foundational to START is that cross-system collaboration. And at the foundation of any successful collaboration is the need to build relationships. And as I said, you've got to learn about each other's practices and mandates and align your values. You have to negotiate protocols for getting referrals quickly within child welfare, for getting clients assessed and into treatment quickly. And you might be identifying gaps in services and developing new services to fill those gaps. So reaching fidelity takes time and a lot of work, but it's worth it because, again, the goal is to replicate as intended so that you produce similar outcomes. So let's move on and talk about the dyad, which is a pairing of a specialized child welfare social worker and family mentor that share a capped caseload of families. This unique pairing of a worker and a family mentor combines great skills and real life experiences. And when a dyad really knows their own role and respects each other's role, they can be super effective at engaging families and together a real catalyst for change. And due to the dyad's intensity of work and start, we say it's like a marriage since the dyads spend so much time together and become like work spouses. They respond to high stress situations together, problem solve challenges, assess readiness, child safety, and all kinds of circumstances with the families that they serve. START workers and mentors are full partners in managing the caseload, but have different roles that sometimes cross over. START teams are very close. They become like family. And there's a mutual respect that actually develops between the worker and the mentor. Now, before I get into their roles, I want to talk on the next slide very briefly about minimum work guidelines. The intensive service delivery of the START model is outlined through the minimum work guidelines, which are actually an essential component to the model. These were established to help staff understand the activities and the guidelines and context standards for working with families. Now, they usually fit pretty well within federal, state, and local guidelines because they go above and beyond, meaning they're more intensive. And we found that this intensity is needed when working with families who have substance use issues. These are only minimum guidelines, and oftentimes jurisdictions choose to increase context standards, and the guidelines actually allow for that local discretion by the supervisor and the team so that they can meet families' needs. So the minimum work guidelines outline guidance and standards for shared decision-making meetings, transportation to treatment appointments, context standards for children, parents, relatives, and resource home placements, drug testing, parent and child time, data entry, supervisor consultation, role delineation, and case closure. So you can imagine, with all the intensity of this work, the mentor and the worker really have to have excellent communication. So let's look quickly at the role of each of the partners. So the worker, thinking about the dyad roles, both the START worker and the mentor have different roles. And I mentioned earlier that a lot of them actually cross over and they might look really similar. So for example, they both focus on child safety and well-being. They both get involved early at that first shared decision-making meeting during that investigation time. Both make home visits to the children where they reinforce effective parenting skills. Both use motivational interviewing to support the parent in making forward movement on their goals. And both assess what sorts of concrete needs the family might have and then link them with resources. Now, there are some activities that are solely the worker's responsibility, but that always include input from the family mentor. Those include developing and reinforcing the case plan and the safety plan with the family, completing court filings and court reports as appropriate, carrying out child placement decisions, securing placement arrangements, making sure the kids get medical care, developmental supports and therapies as needed, and of course, making their own mandated worker contacts. So they're still doing the job of a worker, but they're specialized and more intensive. And on the next slide, family mentors. We know that these are individuals in long-term recovery from their own substance use disorder and who have past lived experience with the child welfare system, or at least they have experiences with their own family that kind of sensitize them to how substance use disorder affects kids and families. They provide child welfare-based peer support services, so their role looks a little bit different than peer support services in mental health or a substance use disorder treatment setting. In general, the role of the family mentor can be considered a subset of the peer recovery support services that are usually provided, since this role specializes in child welfare peer support. And I'll talk more about that in a minute. So what do the mentors do? We know they share that caseload with the worker, and they first and foremost focus on child safety. But beyond that, one of their main roles is actually helping families navigate the system and provide guidance and support when there are barriers and challenges. The family mentor helps connect parents with treatment services by accompanying or actually transporting them to the first 4 treatment sessions, including that initial assessment. It's an opportunity when you're driving them to actually build rapport with the parent and to provide a warm handoff to the treatment provider. Helps the parent feel prepared, and they encourage them, be honest, they tell them what to expect. So it's helpful. And that kind of support actually pretty much ensures that the parent attends the appointment and they're more likely then to return for treatment services. So it helps with retention. Mentors also support parents by introducing them to recovery supports in the community, maybe taking them to their first recovery support meeting, so that parents actually have a healthy and sustainable support system in place once we close their case. Mentors make face-to-face visits with parents in the community and at their home, and they provide coaching about sober parenting, and they serve as recovery role models. Family mentors help support child safety through monitoring, coaching, and reinforcing safety plans, and they can help identify and respond to concerning behaviors or signs of relapse before the rest of the team might even pick up on a problem. Family mentors support relatives caring for children by educating them on what substance use disorders and recovery looks like. They can coach them on the difference between being supportive and actually enabling their family member. And the mentors provide relatives with hope that their own family member might reach recovery by modeling recovery themselves. And so they actually show what it looks like. On the next slide, really quickly, we know peer support is popping up all around the country, and this is amazing. I just think I can't say enough about the beauty of peer support and how much it helps families. Peers can be called different things: recovery coaches, recovery specialists, peer support, family mentors. Historically, substance use disorder and mental health treatment settings have used peer support to assist their patients and clients for years. We're now seeing it in child welfare, courts, jails, emergency rooms. And you can see on the slide some of the benefits of peer support include improved family outreach and engagement, increased access and retention and treatment, reduced rates of relapse, decreased time in foster care, improved family reunification rates, and they change the office culture. And we've seen many of these benefits in START. But I want to spend a little time on peer support in a child welfare setting on the next slide. Basically, the family mentor role is different. In a substance use disorder treatment setting, that peer is focusing on the individual. But in our model, we're looking to actually work with the whole family. So the mentor does just that. We're looking to improve outcomes across the board with individuals and also the family. They're focusing on adult recovery and on building parental capacity, and they do their work through the lens of child safety. So for all those reasons, the START family mentor role is actually considered to be more complex and specialized. And due to this complexity and the uniqueness of the role, and because of the focus on family-centered services, we use the term family mentor to really highlight what that role is all about. And in the chat box, you're going to see a link to our publication, The Use of Peers and Recovery Specialists in Child Welfare Settings. The publication provides an overview of different models of peer recovery supports, along with implementation considerations from 4 programs that have demonstrated positive child welfare outcomes. All right, let's move on to the START Family Mentor, just a little bit more about them. It's a snapshot of some of the data we collected in Kentucky. They spend about 80% of their time in direct face-to-face contact with the family and about 20% of their time working on behalf of families, talking to treatment providers, coordinating services, making referrals. So on average, they spend about 60 hours of direct contact with parents over the life of the case. And our cases actually remain open around between 14 and 16 months on average. Family mentor contact is most intense at the beginning of the case because we're trying to engage families. During that first 3 weeks of a START case, mentors are having contact with the family at a minimum every 3 days and spending a lot of hours with that family. Refusals or no-shows with our family mentors are rare, but our data shows us that each additional no-show or refusal decreased the odds of unification of that family by 24%. So that's really how critical the role of the family mentor is. We also found that mentors made the same amount of contacts for adults who found recovery and for those who didn't, speaking to how they persistently engage families. Aside from how much mentors actually help families, they're also a catalyst for cultural change in child welfare in particular. They help raise awareness about substance use, they reduce stigma, promote advocacy, and they help us know that people recover. They model successful recovery, and sometimes we don't see that in child welfare offices because we often see parents when they're at their worst. So we did a study to learn more about the experience of child welfare workers in START, and we found some really awesome things. We found that START workers reported improved engagement, planning, and shared decision-making with families due to family mentors' involvement, and our quality of casework was above and beyond traditional practice. START workers had increased capacity for empathy and engagement, and that's exactly what we want in child welfare. Additionally, START workers have higher overall job satisfaction and a real reluctance to returning to business as usual after working in this model. And that was my experience after working with START. It changed everything for me, and it just made me a better child welfare practitioner and a better person. So I think just listening to lived experience is just really critical. All right, outcomes. Let's move on to outcomes. Quickly, program evaluation is a big part of any evidence-based program, including START. And we use an empowerment evaluation approach in START, which refers to gathering, analyzing, and using program data and its outcome to actively engage and involve key stakeholders in all aspects of the evaluation and its design and answering key research questions in the CQI process and the ongoing discussion of outcomes. Now, this approach really does require frequent interaction between the evaluator, leadership, and frontline staff to make sure that the evaluation aligns with what's happening on the ground. Part of the program evaluation activities include data collection to monitor fidelity by tracking adherence to the START timeline. We track referrals to START, what cases get accepted, and the beginning and end dates of various activities, including the first assessment, the first 4 treatment appointments, begin and end dates for each treatment episode. We include a measure of sobriety, and then other services and family outcomes. The program evaluation team also is looking at administrative data that's kept in the state SACWA system so that they can track other important information about families' experiences in the system, such as the final case disposition, the child's placement, and also recurrence of child maltreatment. We learned through empowerment evaluation that evaluation is not just a report, it's a process that includes engaging the stakeholders and creating buy-in. Through the continuous quality improvement process, we receive reports about the data that was input by our team, and then we use the data to adjust our practice and improve practice on the ground. This is an approach that's actually used as a key strategy for empowering jurisdictions to engage in larger systems change. So again, this is how we use START as a catalyst for change. All right, outcomes. I've talked all about that rigorous program evaluation and the testing of START in Kentucky, comparing START families to non-START families with similar characteristics. And here's what we learned. Women in START have nearly double the sobriety rates of their non-START counterparts, 66% versus 37%. Children in START are about half as likely to enter foster care, 21% versus 42% in the comparison group. At case closure, over 75% of START kids remained with or were reunified by their parents or with their parents. For every $1 spent on Kentucky START, $2.22 is saved in offset of foster care costs. And I already talked about being listed on both of the clearinghouses. So when the START model is implemented with fidelity, these are the outcomes a site can expect, since this is how the model was tested. Let's look at rates of recurrence on the next slide. START cases stay open about 14 to 16 months on average due to the high-risk nature of the case. Said another way, 50% of START cases are closed in about 13 months. Now, we recognize the need in START to not keep families involved with the system longer than they need to be. So we try to balance that out with the right support that prevents parents from coming back into the system. So looking at maltreatment rates after a START case closes, it was found that within 6 months, the rates of recurrence of child abuse or neglect were indeed lower than non-START cases that were similar in demographics. Of START children who remain with their parents throughout the life of the case, 2.7% had a recurrence of child maltreatment. The matched control group's rate, you can see, was 11.3%. So START was lower than both the matched control group and the overall state average, which was about 5.5%. So this means that fewer START families come back to the attention of child welfare than non-START families. And that's good news because we're keeping them out of the system and preventing that revolving door. I do also want to mention we have a concurrent study on the sustained effect of START. We actually looked at the same group of START children for about 10 years, and we compared them to children receiving usual child welfare services to see if START's positive outcomes are actually sustained beyond the START intervention or beyond case closure. And I'm happy to report that the results are favorable. Effects of START are indeed sustained at both 6 months and 12 months post-intervention, with START families remaining free of both out-of-home care and recurrence of child abuse and neglect at a higher rate than non-START families. So more to come on that once it's published. Let's move quickly to medication-assisted treatment. We did another study of families in Kentucky START families who actually were using opioids. So the use of medication-assisted treatment was positively linked to children either remaining with their parents or being reunited. Among opioid users in START, 75% of those who received at least 250 days of MAT retained all their children, when only 52% of those who received no MAT retained all their children. Even when controlling for gender, race, age, and county, families with more than 250 days of MAT were 2.5 times more likely to keep all of their children in the home than families who received no MAT. And compared to families who received no MAT, The longer a person was on MAT, the more likely the children were to be in the home at case closure, which you can see on the next slide. And we were astonished with some of these outcomes. Compared to families who received no MAT, for every month the parents stayed on MAT, they were 10% more likely to retain custody of their children. So 6 months of MAT, 60% more likely to retain custody of your children. 9 months, 90% more likely to retain custody of your children. And 14 months, about the length of a START case, you stay on it for 14 months, you're 140% more likely to retain custody of their children. And of course, we know that research tells us that the duration of MAT is also positively associated with other things like reducing opioid use and other drug use and criminal activity. So START recognizes that there are many paths to recovery, and it may be appropriate for a parent to receive MAT in conjunction with psychosocial treatment. But that decision is made by the parent and their clinician, and we support that. We also support clients actually being involved in recovery support groups. So that is a snapshot of some of the evidence base for START. And we're going to put a few more resources into the chat box. The first one's a webinar series on opioid use disorders and treatment. And the second one is really cool. It's an opioid use disorder and civil rights video and webinar series. The National Center on Substance Abuse and Child Welfare partnered with the Office for Civil Rights to create this training series to provide information to child welfare and court professionals about federal disability rights protections that apply to some parents with an opioid or other substance use disorder who are also involved in the child welfare system. So check it out. All right, we are closing in here. Let's talk a little bit about the stages of implementation. And you can see on the slide here, the 4 stages. Now that you've learned about the model and its outcomes, I want to talk a little bit deeper about how this works. We know that START is a complex model that can drive systems transformation, and that implementing its essential components takes persistence, patience, and time. We like to say it will be like a marathon, not a race. And you'll learn many lessons along the way to help improve practice. Again, it takes 2 to 4 years to reach full fidelity of any EDP. So let's look at the stages. The installation stage of implementation. This is when the new collaborative is reviewing the elements necessary to actually implement START. In this stage, you would be determining who needs to be at the table, what policies, skills, training, and support is necessary to implement the model. You might be hiring or assigning staff and getting them trained in the model. Now, this is the stage that sets the foundation for everything that follows. So don't underestimate this stage. This is the time to be thoughtful about creating a governance structure and support needed to be successful. The installation stage takes a minimum of 6 months and sometimes longer, depending on resources in your community and if there's a need to actually build a basic infrastructure and a collaborative team. Once a jurisdiction begins serving cases, the collaborative will enter the initial implementation stage, which can last from 1 to 3 years, depending on what model elements you already have in place in your community. This is when you begin testing out the policies and procedures that you put in place to support the program. Now, some things are going to work and some things aren't. So flexibility is really the name of the game as staff learn how to put all the puzzle pieces together. Many things are going to change during this stage, and that's okay. Just keep at it. It's about adjusting practice and learning a different way of doing business. And as staff get more comfortable with the practices embedded in START and START service delivery becomes second nature, and it will, the collaborative enters the full implementation stage. Now, this phase typically begins 3 to 5 years after initial implementation, depending on your jurisdiction. And at this point, the site would be eligible for START certification. This is the time you might also have preliminary outcomes. And finally, the team will reach sustainability, which is when START is ingrained in how services are delivered to families. This is when staff and leadership fully embrace START practice. Efforts begin focusing on the continuation of improving practice and of actually growing your program to meet the need in your community. The practices spread and become embedded in your organization. Policies begin to change, and you begin to see outcomes change for all families. It's a beautiful thing. And finally, let's talk very briefly about implementation considerations on the next slide. So you want to look at your data. What's the need and what issue are you trying to solve before you even select START or any other EDP? You want to look at state and county level data about the child welfare population and the availability of treatment resources. What does the data say about the need of this population? Collaboration and partnership. What's the status of your collaboration between systems and agencies in your community? Child welfare, treatment, courts, maternal and child health, and other family serving entities. Is there an existing partnership or collaborative that you can build upon? Or does this work still need to begin in your community? Aligning initiatives. What other initiatives exist and actually serve this population? How will they align? Are there enough families to be served by all the initiatives in your community? And how can you build on what already exists in your community? Treatment and recovery supports. Is there a full array of treatment? Detox, outpatient, intensive outpatient, residential, MAT. And are there recovery supports in your community? Sometimes communities need to build an infrastructure of treatment and recovery supports before they can actually successfully implement the model. And some communities have actually used START to build that infrastructure. Resources, costs, staffing capacity, what would be needed to move forward with implementation, and leadership. I can't say enough about strong leadership. Is there support and buy-in from leadership in child welfare and treatment first and foremost? The courts? What about other partners? Without strong leadership, we know it's really hard to sustain any of these programs. Also, does a jurisdiction see a window of opportunity and have openness to practice change? Because if nothing changes, nothing changes. We know that shifting our paradigm to a prevention focus is going to require that change in practice and possibly policy. Capacity for continuous quality improvement, which is a critical component to any practice improvement effort. And finally, sustainability. What's the long-term plan for not only funding, but the institutionalization of the practices into your organization's approach to working with families? Are all families who need the service able to access it? What needs to happen to actually make this happen? So that is a lot of information, and I thank you for hanging in there with me today.